Okay, the first question, suspected pacemaker, ICD, endocarditis, should lead be extracted? I would say, in a febrile patient with no definite criteria, like don't jump the gun because it's pretty morbid to take out a pacemaker, but in the case I showed you, yes, absolutely. Okay. Second question. I did not know that echo criteria were guideline-based reasons for emergent operation, absent embolization or clinical heart failure. There it is, I can't remember if it's 2B or 2A, if the vegetation is on the anterior mitral valve leaf and is more than 15 millimeters, that is an indication also for emergent surgery. And also abscess and prosthetic valve endocarditis, it doesn't matter in an abscess if you've cleared the blood cultures because you're not going to clear the infection in the abscess. And so you need a surgeon who knows how to do a deep debridement and really clean up the area, make sure it's well cleared out before they put the new valve in. And then surveillance for emergency surgery is really key because you won't have sterilized the blood cultures.
Thank you, Sue. There were just one quick question for either Marty or for Amr, and this has to do with core valve and whether the fact that you have core valves, and does this make diagnosing a perivalvular abscess or an aortic ring abscess an issue by echocardiography? Has this ever come up? I know you both have a lot of experience. Any guidance to the audience on this?
So that's a very interesting question. About a month ago, one of our fellows, first-year fellows, had to do an emergent echo with a sonographer on a patient who just had a core valve earlier in the day. And he was sure that the valve was avulsed and there was a paravalvular space. The issue with core valves is that the core valve doesn't necessarily lay across the aortic valve. And so sometimes there can be a gap between the aortic sinuses and the core valve that if you aren't trained to see what it looks like, it can appear to you that there is a space or an infection or a hematoma or whatnot. So typically speaking, we get echoes the next day or before their discharge, and we again identify what the normal anatomy looks like. But to an untrained eye, people who do this day in, day out, you can make a distinction between what's a normal looking appearing core valve and what isn't.
I would agree. I haven't had we've done a number of core valves at Temple. We haven't had any with any kind of endocarditis complications as of yet. We've been doing them for 2 years. But they're pretty easy to see and evaluate, so I would agree.
So I'm going to go ahead and proceed with assessment of prosthetic talk again about the pressure recovery phenomena. So I think what really is the key difference here is when we say pressure recovery, we're not talking about the pressure gradient. We are talking about the absolute pressure. Okay? So I'm going to show this point here again. If we start out with an LV pressure of 100 millimeters of mercury, okay, so the LV pressure is 100 millimeters of mercury. The flow converges through the geometrical area towards the vena contracta. And some of that flow, some of that energy of flow is converted to heat and lost into friction forces and vortex formation, and some of that energy is dissipated. So the actual absolute pressure would drop at the vena contracta to 70 millimeters of mercury. Okay? So you start out with a pressure of 100, drops down to the vena contracta at 70. So your echo gradient here is 30 millimeters of mercury. Okay? Now what happens is some of that pressure reconverts back from kinetic energy to potential energy or pressure energy. So initially when kinetic energy as movement is forcing with velocity is converted from potential energy to kinetic energy, some of that energy is lost as heat. Then it reconverts back into potential energy. So potential, kinetic, potential, and in doing so, pressure recovers again. So upstream, the absolute pressure now is 90 millimeters of mercury. Okay? So if you look at this patient has an echo gradient of 100 minus 70, which is 30. When he went up to 90 absolute pressure, his cath gradient is 20, and his pressure recovery is 20. Okay, so echo gradient 30, cath gradient 10, and pressure recovery is 20. Okay, so 100 millimeter of mercury dropped to 70 at the vena contracta and increased back up to 90. The gradient is the difference between 170 for echo and between 190 for cath. Is that clear? So the actual pressure gradient is higher by echo, lower by cath. The pressure recovery is the difference between this and this. Okay? That's the difference between the pressure recovery. Now look at the other scenario. This next patient started with 100, fell to 70, but had no pressure recovery at all. So upstream from the vena contracta, his pressure remained at 70. So this patient has an echo gradient of 30, a cath gradient of 30, and no pressure recovery. Does that make it clear? Or shall we say it again? Who wants me to repeat? Raise your hand. I'm sorry?
Why is there no recovery?
In this particular case, this happens when you have somebody who has a large aortic diameter or has an eccentric jet. So you're not going to have pressure recovery if your aorta is not allowing for pressure recovery if it's large, or if you have an eccentric jet where there's been a lot of energy that's been dissipated and lost and converted to friction forces and heat. Now, when I talk about pressure recovery, I am not talking about the difference between peak-to-peak gradient and maximum instantaneous gradient. That difference is there forever and eternity. It's differing 2 different points of measurement. That is not applying. The pressure recovery concept applies to the mean gradient and the mean gradient only. Normally, there is no significant pressure recovery. There is no. That's why your mean cath gradient is just as good as your mean echo gradient. You have a lot of pressure recovery when you have a small aorta. And these are the elder ladies who have moderate aortic stenosis. You get a patient who has a moderate aortic stenosis, and you do a Doppler on her. She has an aorta of 2.2. Her gradient is going to be calculated at 30. You send her to the cath lab, and your partner does a selective coronary angiography and crosses the valve and tells you don't know what you're talking about. I got a mean gradient of 18. Okay? That lady had significant pressure recovery. And she had significant pressure recovery because her aorta was small. So it becomes clinically significant, this phenomenon of pressure recovery, when it is present to a great degree. And it is present to a great degree in 2 circumstances: in small aortas with moderate aortic stenosis and in the cases of valve prosthesis. It just happens again in valve prosthesis as well that there is a significant amount of pressure recovery. So if you were to cath a patient with a mechanical aortic valve of 25 millimeters of mercury mean gradient, if you cath him, you will not have a mean gradient of 25. You will have a mean gradient of 10. Okay? So again, there is absolute recovery of pressure leading to a decrease in the pressure gradient.
Does the pressure increase again because it becomes laminar, the flow?
Because the loss of potential, when potential energy that's stored in the ventricle gets converted to kinetic energy, that's a pressure, that's an energy losing phenomena. A lot of the energy, because of the turbulence, Reynolds number and viscosity and friction forces and forming of vortices, all of that gets dissipated as heat and friction forces. And so some of the pressure energy gets lost, and that's why you have a pressure gradient. After a while upstream, the flow becomes laminar, there's less friction forces, there's reconversion of the kinetic energy to potential energy, and some of the pressure recovers. Not all of it, some of it recovers. And when it recovers, the pressure gradient between the left ventricle and the aorta then decreases. Yes, sir?
In this case, if there is pressure recovery, who is clinically correct?
That's an excellent question. So,
There are a lot of questions on that.
yeah, and that's it. So this is very pertinent. So, in reality, the brain, which is the second most important organ if you're a cardiologist, the most important if you're a human being, It is actually the pressure recovered that the brain sees. And so it's the cath gradient that is accurate in those circumstances. Okay? Because Doppler assumes there is no pressure recovery, which is incorrect in certain situations. In the majority of the time, they're the same. In that particular group of people, in prosthetic valves and in small aortic diameters, it is the cath gradient that is accurate.
Wouldn't the LV be subjected to all the higher gradient though?
I'm sorry?
Wouldn't the left ventricle, be subjected to all the strain of the higher
Of the cath gradient, not of the Doppler gradient. The question was, would the ventricle be exposed to that extra gradient? Correct. It'll be exposed to the cath gradient, not the Doppler gradient. Okay? So the Doppler gradient is not necessarily the real or the energy that the ventricle sees. It's the cath gradient. It's the difference after the pressure recovered. That's what the ventricle has to pump against.
Can we remove this controversy by putting a sample volume later than the
No, you won't. I'm sorry. The question was, can you remove this controversy by putting the sample volume more distal? So the short answer is no, that isn't the way to do it, but there is a way of calculating this energy loss coefficient, which is multiplying the ascending aortic diameter obtained at the sinotubular junction by the effective orifice area obtained by echo and dividing it by the difference between them. Okay? That is the way you relieve the controversy.
I think we should move on to...
Okay. So can you please bring up my board questions? If anybody has any questions, they can catch me outside here. I'll be around for a few minutes. So let's talk about some board review questions. 75-year-old patient with CAD, history of bypass and bioprosthetic aortic valve replacement, complains of progressive shortness of breath times 4 months. Here's your echo. Here's your Doppler. So the question is... This is your TE. So the question is, the severity of prosthetic aortic stenosis is mild, moderate, severe, need more information. Sure. Okay, you know what, I'm sorry, can we go back? Okay, so here you go. Here is an LVOT of 0.8, TVI of 22. Your aortic velocity is 4.5. Your TVI is 122. This is the shape of your jet. And this is your TEE. And this is your short axis view. Okay? So, severity of prosthetic aortic stenosis is mild, moderate, severe, need more information. So we have, that's actually perfect. It's between severe and need more information. And the answer here that I have is need more information. And the information that you need, as we showed, is the Doppler velocity index. You need to calculate at 0.18. I didn't give you that information. And the acceleration time is 120 milliseconds. So now you can confidently say the velocity was greater than 3, your acceleration time was prolonged, and your Doppler velocity index was 0.18, which again was decreased. So again, this patient now, with that degree, has, get ready for your responses, mild, moderate, severe, or need more information. Perfect. Somebody still needs more information. I don't know what more information. Catham, I guess. I think I'm going to move over so we can, listen to some questions from Dr. Keene and Dr. Dig. Go. Okay, one more and then we'll move over. Okay. Can we go to the next question? And this is actually what the finding was on surgery. As you could see, pannus formation And you can clearly see that, again, we didn't really see much on the TEE, and that is not unusual with Pannus formation in biprosthetic valves. So the pathology of prosthetic aortic stenosis is, this is a question. Perfect. And the answer is difficult to be visualized by echo. Pannus is not something you can actually miss it completely in 30% of the time. And that's kind of what we saw with that. Okay? And so the patient had biprosthetic valve stenosis due to Pannus formation as evidenced by elevated velocity, decreased DVI, prolonged acceleration time, and inadequate visualization of the Pannus column. Okay. This one might create a little bit of some controversy, so hold your horses. 65-year-old CAD and bypass. The patient came complaining of progressive shortness of breath and chest pain times 2 months. He had end-stage renal disease and was receiving hemodialysis through an AV shunt. Old and mature AV shunt. So this is his parasternal view. And this is his velocities. He's got 1.2 almost LVOT velocity. He's got a TVI of 29. He's got a Vmax of 4 meters per second above, a mean gradient of 37, and a valve area estimated at 0.7. This patient was taken to the cath lab, so this is information that we have, but you've got a mean gradient of 40, you've got a cardiac output of 12, and you've got a valve area of 1.5. Okay? So huge discrepancy between cath and echo, not in the gradient, but in the valve area assessment. Okay? So what is the severity of aortic stenosis? Okay, so need more information. I think that is the correct answer. We have discrepant data between valve area and we have an elevated gradient. So let's see what more information we obtained here. So this is a TEE. In these discrepant areas, as Dr. Keene highlighted, this is where planimetry might be extremely very helpful. You have to actually visually look at the valve to get a better idea about whether it's truly stenotic or not. So this is your this is your long axis view in your TEE, and this is your short axis view, and certainly the valve is thickened and calcified. We actually were able to obtain an aortic valve planimetry of 1.5 centimeters squared, and you can see the M mode here, not really suggesting critical aortic stenosis by any means in the M mode images that Dr. Keene showed earlier. And so if you look at this, you're thinking now high gradient is the jet eccentric. This is his jet. Again, you see it's not eccentric. It's filling the entire aorta. And then we did a maneuver on this patient, okay? And after this maneuver, this patient's velocity fell from 1.2 to 0.9. His TVI fell from 29 to 25. His aortic velocity fell from 4.2 to 3.5. And his TVI fell from 100 to 89. So what was the maneuver that we did? Did we give him dobutamine? Did we exercise? Did we give him a fluid channel? Or did we do fistula compression? Go ahead and put in your answers.
That's a good one. Press on the fistula.
I don't think it's on. It doesn't look like it's on.
Oh. Okay, they didn't do this one. Anyway, so how many of you think it's dobutamine? Exercise? Fistula compression?
Wow.
So the severity of aortic stenosis is, how many of you think it's mild, moderate, severe? Perfect. So it's somewhere between mild to moderate. It's clearly not severe. And can we advance, please? It's stuck. And what the patient had was a 90% stenosis in the saphenous vein graft to the PDA, and this is obviously the cause of his symptoms. He received revascularization with a drug-eluting stent and his symptoms disappeared. So this patient had a high gradient, large area. Here was a case where the geometrical area really helped us out. He had a dialysis shunt with high flow as determined by the cardiac output. With compression, the gradient decreased in the cath lab to 27 millimeters of mercury and to 30 millimeters mercury in the echo lab, and he has moderate aortic stenosis with acute coronary syndrome. Okay?
Great case.
Keen, thank you very much.
Great case.
Great case. Thanks, Dr. Abbas. So we're going to move on in the interest of time, and Dr. Kane is going to present a few cases.
Very good. Thank you. Okay. I have nothing to disclose about these cases, but I have a confession. I think, we're all friends now. I can confess. I suffer from template envy. It's very bad. It's tough. It's been developing over the last 3 years, Dr. Mankad comes in with these beautiful templates, gorgeous, very imperial-looking Mayo-esque buildings, and my template, I don't have a nice template. I mean, but, then I thought to myself, it's Philadelphia, for God's sake, and I work at Temple, in the slums. So I needed something a little grittier. So that's my proposed Temple template. Yeah, I thought that worked better. It's more atmospheric, I think. That's actually the 80-year-old, the former School of Medicine building being taken down this past 6 months. It's now just a grassy knoll. But you got it at a good time. Anyhow, let's talk about a case. This is a gentleman by the name of A.K. I'm losing my mic here. Okay. 65-year-old gentleman with worsening shortness of breath and easy fatigue. He gave a vague history of aortic stenosis. Really didn't have much data on him. His hypertension, hyperlipidemia. We'll see momentarily that he is slightly obese. He has obstructive, that should be OSA, obstructive sleep apnea, as well as obesity hypoventilation syndrome. Blood pressure was 140/70. He's 5'8" tall and 383 pounds. His BMI is 59.9 kilograms per meter squared. On physical exam, he had a single S2. S2 overall was decreased, and he has a 3/6 late peaking murmur, which radiates into the carotids. So here's his echocardiogram. Our techs were very frustrated with the quality of the TTE, but it was acoustic windows were limited. So we can see he's got what appears to be maybe a somewhat calcified aortic valve here. Hard to see in the short axis. Looks like the opening is decreased at least. The mitral valve looked pretty okay. We did the apical 5-chamber was basically such that you could tell it was an apical 5-chamber, but you couldn't see the endocardium very well. His EF was known to be reasonably normal. So we have this data that was obtained. We have an LVOT VTI of around 28 centimeters. We have this is the right sternal border with the PED off. We have a VTI of 105. The Vmax was 4.3 meters per second. His max gradient was 72, and his mean gradient was 40.9. And again, you can go on this. The computer was calculating it based on this data. It did get recalculated based on repeat measurements and not averaging. The LVOT diameter was 24. So here's the summary of the reported echocardiographic data. The peak velocity was 4.3 meters per second. Mean gradient is close to 41. Calculated valve area was 1.2 centimeters squared. The aortic valve index, which I unfortunately raced through, actually raced past in my talk, but there was a question, so I think this was a good opportunity to bring it up. This is the valve area correlated to body surface area, corrected for body surface area, was 0.5. And the dimensionless index, the Doppler velocity index, the obstruction index, whatever you prefer to call it, was 0.27. Okay? That's the data. So, here's the question. What do you recommend? Shall we take this gentleman for high-risk AVR? Should we send him off to the TAVR team for consideration for TAVR? You know, should we just see, you know, maybe he's just, you know, doesn't really have severe AS. Maybe we should see if we should do a treadmill test and see if we can enhance his, of course the treadmill might not hold him, but, you know, we could see. A dobutamine stress echo, or just simply refer to the bariatric surgery program. That's an interesting spread. See? 4 and 5? Yeah. Well, you know, 5 might be okay, but, you know, if you do think that this is severe AS, you know, the bariatric surgeons probably aren't all that excited about taking him to the OR, so, you know, that could be a problem. A dobutamine stress echo. Let me just go back and, if I can go back. What was his stroke volume was 140 divided by 60, so that is actually low. Yeah, one could argue, you know, potentially seeing if you could enhance see if we could bring this down, but actually, you know, most people wouldn't do a dobutamine stress echo until this was closer to 1. So what people decided to do was that we should probably just cath him first. See, dastardly. His right heart cath, and unfortunately this was done in an outside hospital, he had moderate to severe pulmonary hypertension. His PA systolic pressure was 59/18. His wedge pressure, maybe not surprisingly, was 27. At an LVEDP of 37. Now that seems excessively high. We questioned that, but, you know, well, this is the data we were given. His cardiac output was 5.2, but of course when you correct for that, his index was pretty low. And, you know, we see his stroke volume index is low. AV assessment was a mean gradient of 42 millimeters of mercury, and actually in cath they calculated a valve area of about 1 centimeter squared. He does have some circumflex disease in the OM2, but, you know, his left main LAD and RCA were pretty benign. So we have some mixed data. So has the cath data helped you at all? Has it changed your mind? Do you want to do a high-risk AVR with a bypass? Do you want to send him to the TAVR team and recommend sort of a staged PCI, perhaps? Do you still want to try and torture the stress lab and put him on a treadmill? Should we do medical management for now, or you don't believe this is severe AS, just go to the bariatric surgery program? So bariatrics has gone down dramatically.
Lost hope.
There you go. So people are thinking more surgically inclined, and it looks, or medical management. Actually, it's quite a conundrum. Well, there was a lot of argumenting. Argumenting, is that a word? My dad was an English professor. He'd be mad. There was a lot of arguing regarding this. I'm wondering what my panelists think.
I missed his symptomatic status. I was talking.
He used to be able to walk from the bed to the bathroom.
That's
but
it?
now he
Gets from the bed to the
he gets halfway
bed to
across
the end
the
of the
room
bed.
and he this is literally true.
Oh boy. This is a, you know, obviously a tough one. I would vote for number 1, I guess.
I think I'd vote for number 1. Well,
I guess you missed. He's going to beg off. Yeah, I mean, basically, I think I can't remember. He was presented at our structural heart disease conference, and I do believe people felt pretty strongly that with the cath data and the valve area at cath being, the mean gradient being about 42 at cath and the valve area being 0.9-ish, 1-ish, and as well as the valve index being 0.5 or 0.4, I can't remember, that he probably does have severe aortic stenosis, and it just shows you that it is important to work in the body surface area. Did you have a quick question?
Yeah. So, he's got obstructive sleep apnea. Those guys get very short of breath.
Yeah.
But
What's that? Well, we'll see. The surgeons are seeing him. They're getting one surgeon is getting a second opinion.
Well, the one thing about putting in a prosthetic valve in this guy is, you are going to give him a pretty narrow orifice there, unless you can get a big valve in him. TAVR has less, less patient-prosthesis mismatch. But, he's young. He's young.
Yeah,
is the
and
problem.
there were issues with TAVR, including there was basically no femoral access. Although the surgeon said that he didn't mind the 13 centimeters cut down. His aorta is actually pretty retrosternal, so they're a little bit anxious about that as well, and nobody really wanted to do a mini thoracotomy. Yeah. So this is tough, but I think my point is, I think the ultimate decision was this definitely was severe AS. The valve index is helpful, particularly in particularly tall people or particularly large individuals. And so I apologize for sort of breezing past that in my discussion of AS, but it is something important to consider.
Question.
Yeah.
So, not belaboring the point, but would this be an ASE recommended procedure?
Well, he fits the criteria. I mean, ASC isn't going to really recommending surgery.
Well, he's short of breath. The point was made. He has a million reasons to be short of breath. How do we know that it's from the aortic stenosis? And do we have a reasonable expectation that it's...
Yeah, well, his PFTs have not changed over time. Again, in the interest of time, I didn't bring all the data in here, but his PFTs haven't changed over time. His obesity hasn't changed over time. He's had OSA for about 10 years now. Certainly possible that he's developing progressive pulmonary hypertension due to the OSA. It's a tough call. So, he's currently in the debate between TAVR and...
and he certainly needs to make major lifestyle changes also. There's no question. But you're not going to fix that in the short term here.
It's a tough call. I don't know what his blood gas was. I don't know that they did a blood gas. What's that? Yeah. Okay, let's quickly do case 2, and then Dr. Tide can take over. Case 2 is a 38-year-old gentleman who is complaining of decreased exercise tolerance. He's an avid biker who used to go about 15 or 20 miles without symptoms, but now at about 5 to 10 miles, he says he's developing severe shortness of breath and dizziness, severe fatigue. He's otherwise a really fit person. He does have a past medical history of coarctation of the aorta, status post patch repair at 17 months of age, and he knows that he has a bicuspid aortic valve, but he was never ever told of bicuspid aortic stenosis. On physical exam, he has a normal blood pressure. He's 5'9" as well, but he's only 176 pounds. His BMI is 26 kilograms per meter squared. He has a 3/6 crescendo murmur, but a preserved S2. Here are his echocardiograms for your contemplation and perusal. Parasternal long axis view.
It's a beautiful case.
Moving along.
He's like a Jones guy.
Short axis, you can see his bicuspid valve. Seems to be some, turbulence going on in there. Why these aren't moving. Okay, this is apical long axis view. We had a better apical long axis than we did a 5-chamber. Peruse and consider.
You can see just the way, you can just, even if you didn't see it, see the way that the anterior leaflet cans itself.
And here's his apical 5-chamber view, where you do see a little bit of AI, at least. It was hard to open the LVOT for some reason. Anyway, despite the fact that the technologist could not open the LVOT, we did get an LVOT measurement using pulse wave Doppler, and the LVOT VTI was surprisingly high at 54.6, I believe that is. And putting the continuous wave across, we get a VTI of 61 with a peak gradient, max gradient of 32, a mean of about 18. So what is your diagnosis? Is this bicuspid aortic stenosis? Is this hypertrophic cardiomyopathy with LVOT obstruction? Is it a subvalvular LVOT obstruction of some other sort? Are you going to argue the fact that the DI, the dimensionless index, is only 0.89? There can be no obstruction. Or, as always, do you want more information?
That's my line. It's a great case.
Very good. So people were very observant. That's very nice. You noticed that he had a very unusual looking outflow tract. He took very pretty pictures. And he indeed probably has a subvalvular membrane. Basically, we had cath data here. Wait, back. Here is the mid-LV to AO. So you can see here that the LV, there's quite a bit of a gradient there in the mid-LV to AO. But when you pull back to the formal LVOT, the LVOT AO, there is no gradient whatsoever. So his stenosis is clearly subvalvular, and he has a subvalvular membrane. That's just the pullback there.
Can you show it again, the membrane?
Sure.
Is there any pressure recovery? Just kidding.
A lot.
No.
So
there's the membrane there. It's a crescentic sort of a lesion. You can see almost a hinge point in his anterior leaflet where there's some more thickening. If I go back a little bit further, it's a little bit more obvious in the parasternals. You might.
Where they put the pulse wave is in the wrong place. I bet you they put the pulse wave.
And you can see that the turbulence begins well before the aortic valve. It's kind of interesting here. This, a lot of times the membranes are very close to the aortic valve, and when that turbulence can create some valvular regurgitation, but he's not. It's convenient not only in the fact that he has a pretty competent bicuspid aortic valve, but that big gap of LVOT made for a very nice pullback. So it was very nice of him to do. The frustrating part is, of course, here you have a guy with a subvalvular stenosis with a mean gradient of 18 and a peak gradient of only 28 to 32. Who's fit and healthy. He's still riding a bicycle, 5 miles maybe a day, 5 to 8 miles a day. Could do 15 or more before, so he feels really symptomatic. So what do you recommend? That was the left heart cath that I showed you. Oh, I believe his coronaries were normal.
Just watch him for now. It's not high enough.
Wow, resection of the subvalvular membrane, pretty aggressive. And 26% said do nothing, with some other dissenting opinions. Yeah, this case, again, created a lot of debate about what to do. And I think, actually, the practitioner who's taking care of the patient is here at the course, and he's been scratching his head as well, because it isn't really that much of a subvalvular gradient. I was a little dastardly in the fact that I knew he had a subvalvular membrane when he came in, but they dredged up pediatric cath results from St. Chris's from 1990 or 1989 or something like that. And his gradient across the subvalvular membrane at that time was 28 as well. So that makes it a little bit harder. One might say, okay, let's resect the membrane, even though it's mild, but having that extra information that he had a subvalvular membrane as a child, and it's really hasn't changed all that much. I think the decision has been to hold off. Of course, in typical Philly tradition, yo, dudes. By the way, my daughter tells me that you can call a female a dude because she calls her friends dudes. Anyway, did we forget something? And he did have that history of coarctation, but there's no gradient across his coarct. So that I'll call it a day there. But that's a neat case, I think.
So I was asked to answer a question for Dr. Wiggers, and the question is, do all patients with Staph aureus bacteremia require or need a TEE if good quality TTE is negative and another non-cardiac source is found? So the answer always is in guidelines somewhere. So I showed you this slide earlier, and I focused on the prosthetic valves. But if we go at the top, this is what is suggested in the most recent ACC/AHA guideline recommendation for valvular heart disease for imaging for suspected endocarditis. Of course, you get your blood cultures. Your first test is a TEE. So I don't know if there's any other issue with this patient, but Staph aureus bacteremia without known source, a TEE is a 2A indication. If you have nosocomial Staph aureus with portal of entry known from extracardiac source, it's a 2B recommendation. So it really depends on the no other source. So it looks like this is a 2B recommendation in this patient. Okay? Just get the guideline and take a look at it. A nice little chart there for you. Lots of choices here, though. It gets tougher all the time. All right, so let's do a couple of cases and we'll wrap it up. How's that? So let's see. Valvular cases. Here we go. Okay. So I don't have audience response, so I'm going to ask you guys to sing out the answer here, I guess. So this first case is that of a 61-year-old man who comes to hospital with progressive shortness of breath, back pain, and weight loss that's been going on for several months. 2 weeks earlier, he developed some orthopnea, and he presented to his doctor, and he was given an oral antibiotic for presumed pneumonia. He got a Z-Pak probably. He was transferred from an outside hospital for further care. Quickly, he's had a type B aortic dissection repair. He's a manual labor, non-smoker. You can see the guy's pretty sick. He's on a 50% face mask. He's got JVD and RALS. He's got a holosystolic murmur at the apex and a diastolic decrescendo murmur and some edema. It's a white count. He's anemic, first-degree AV delay, pulmonary edema on chest X-ray with bilateral effusions. So this patient had a transthoracic echo initially that was not very good quality because of his body habitus, and he was so sick. So he got a transesophageal echocardiogram to evaluate cardiac function. So we're going to spend a couple of seconds here. Here's a 0 degree, almost a 0 degree view, looking at the anterior leaflet of the mitral valve. Orthogonal view, looking at the anterior leaflet of the mitral valve. Aortic outflow. Everybody's okay with this? All right, we've consumed it. Okay. Another look at the mitral valve. Oops, I don't know what happened there. Took my... It's doing funny things here today, guys. I don't want to go to slideshow. That's weird. Okay. Let's try. Went right out of the slideshow. All right, doesn't like that, huh? Let's try again. That's very strange. Back to the slideshow. Here we go. Okay. Okay. And I'm going to turn on the color Doppler. Okay?
Many pieces.
Too many pieces. Okay. So based on the history and the TEE images, and we can toggle back, which one of the following most likely explains the mitral valve findings in this patient? Is this myxomatous degeneration, a congenital diverticulum, a pseudoaneurysm of the mitral aortic intervalvular fibrosa, aortic valve endocarditis, or a mitral valve blood cyst? You guys want to go back and look at some images again? Okay. We'll go back one more slide and we'll run it again. So we're looking at the mitral valve here, focusing on the mitral valve finding. Okay. So who votes for this is myxomatous degeneration, degenerative valve disease? I see no hands. That's great. Okay, congenital diverticulum of the valve. Nope. A pseudoaneurysm of the mitral aortic intervalvular fibrosa. I've seen some hands come up. Lots of hands come up. Good. Endocarditis involving the aortic valve. I see a similar number of hands, or a blood cyst of the mitral valve. Okay, so let's go on. So the correct answer here is that this is endocarditis involving the aortic valve, and this is a mitral valve aneurysm. And here's a picture from Dean Corrales, who practiced right over here at Hahnemann many, many years ago. And it illustrates the area of the subaortic apparatus. So this is a case of aortic valve endocarditis, and aortic valve endocarditis often has subaortic valve complications, which could involve the mitral aortic intervalvular fibrosa, which is this fibrous connection between the aortic root and the anterior mitral leaflet, or it can involve the anterior mitral leaflet. So here is a diagram from Dr. Corrales' paper in 1992. So this is the area of the mitral aortic intervalvular fibrosa. Complications from aortic valve endocarditis, which may involve this area, include an abscess in this area, a pseudoaneurysm involving the intervalvular fibrosa, pseudoaneurysm with rupture into the left atrium, or a perforation at the base of the mitral leaflet. Now, what this patient has is this complication, I believe, which is a pseudoaneurysm of the anterior leaflet of the mitral valve. You see the bulge is from the outflow, the opening is in the outflow tract and bulging into the left atrium. Another possibility is just a perforation of the valve. So here's another example. This is a case of a mitral valve aneurysm. And you can see this patient had aortic valve endocarditis, and it's a drop lesion. The jet of the aortic valve, endocarditis, comes back, strikes the anterior leaflet, and causes a perforation in the leaflet and an aneurysm that bulges into the left atrium. Sometimes these are perforate, sometimes they are not. But as opposed to a congenital diverticulum, which bulges from the left atrium into the outflow tract, that's why that's not the correct answer. The intervalvular fibrosa area is in here, so that would not be the correct answer. A blood cyst is very rare, but it would not be perforate like this. It can occur on mitral valve, can occur in the ventricle, tricuspid valve. We've seen a couple in the ventricle, actually. And the last answer? Losing my... and myxomatous degeneration. This is very unlikely to be myxomatous degeneration. So let's go back and look at the mitral valve. And you can see, if you look at it very carefully, you can see the perforation here in the leaflet. And this is a aneurysm or pseudoaneurysm of the mitral valve. I don't know, any thoughts, Jerry or Marty?
It's great. It's great.
And you can also see there's a little vegetation on the aortic valve, and you can see it in this plane right here.
That's straight down.
And then you have a PISA. Everybody loves PISA. Here's significant aortic insufficiency, and then there's a perforation in this mitral valve aneurysm and an eccentric jet of severe mitral regurgitation, explaining his symptoms. Everybody okay with that?
You might be able to use that piece on the aortic, that piece on the aortic valve. I think you could use that to do an EROA.
We could do that.
Definitely.
All right. Let's move on to another case. Okay. So case 2. This is a lady who was sent down from an outside hospital to the echo lab, and I know Kushtav was hitting the table with his shoe and said, I want a TE on this patient immediately, and I was sitting there, so I kind of stopped these kind of things. But here we go. 84-year-old lady who has stage 4 chronic kidney disease and systemic hypertension who presents to an outside hospital with dyspnea. Physical exam and chest x-ray were consistent with some mild pulmonary edema. She was given diuretics, and they did a transthoracic echocardiogram. We repeated it when she came down because they didn't send it. They wanted to get a TE immediately. But here's the transthoracic echocardiogram. So parasternal long axis view, Doppler. Okay. Everybody's good? Yes? Okay. Next view. Short axis view, parasternal short axis view. And I'll let this play for a little bit and you see several clips of it. And we're going to focus on this right here. Okay? Apical 4-chamber view. Topic pregnancy. And long axis view. Okay? Is everybody seen enough? Want to take it in again? Yes? No? You're too stunned? Okay. All right. So let's look at the question, then we can go back. So which of the following entities constitutes the most likely etiology for what I showed you? Is this a left atrial myxoma, an intracavitary thrombus, complication of infective endocarditis, caseous calcification, or a papillary fibroelastoma? So who votes for left atrial myxoma? Very good. Intracavitary thrombus? Nope. Infective endocarditis? Nope. Oh, one over there, okay. I saw a couple over there. Caseous calcification? Yeah, that's it. You got it. And papillary fibroelastoma. Okay, so let's go back. First look at the images, and then we can go into this little explanation. So here's the parasternal long axis.
I think I should point out that we have more things at UMass besides these toothpaste tumors and mitral valve aneurysms.
This is
508 area code has a lot of that.
This is what I saw just last week at the lab, though. But you can see this rounded mass that's here in the posterior annulus. And if you look at this carefully, and I think it's better seen on the short axis, you can see a rim of calcium and surrounding echolucency. And this is very rounded. Mitral annulus calcification doesn't tend to be so rounded up. So this is a localized, rounded area with a central echolucency. And it's seen pretty well in these other views. I don't know if Marty or Amr has any thoughts, but so this, I believe, is caseous calcification. I told that they didn't need a TEE, and don't call the surgeon. So this is relatively rare, but maybe underestimated in echo labs. From what's in the literature, the estimated prevalence is about 0.07% of all echoes. What we see is an annular-based mass, rounded annular-based mass with central echolucency. It has if you open this, what would exude would be a putty-like admixture of fatty acids, cholesterol, and calcium, and it's also known on the street, as Jerry would say, as a toothpaste tumor. It's classically located in the posterior portion of the annulus. It's often associated with the elderly, hypertension in women. The natural history, as Yitzhak said yesterday, is relatively benign. You don't want to send this person to the operating room unless you have to, and there have even been documented cases of regression of this phenomenon. The differential diagnosis includes an abscess, tumors, or thrombus. So you guys got that one. I think that's a pretty classic case. And multimodality imaging, here's what it, I think this is the mozzarella cheese we had last night on the pizza, Jerry. But this is the putty-like admixture, and you can see this rounded annular mass with a central area. It's just a shell of calcium, and inside is this putty-like admixture of so-called toothpaste tumor. Okay? I'd imagine, well, it's annular calcification, so I'd say it's associated with it. Conformed Frust, I don't know. She probably is an old elderly lady with hypertension and chronic kidney disease, so she likely has atherosclerosis. I'm going to skip ahead to a couple of other cases here. Okay, so you saw this. Marty gave you this case as one of the board review questions. And this actually was on my boards, but they were not nice enough to give me the time. I had to figure it out by looking actually at the timing that came with the Doppler tracing here. So I've given you this time from this point here to this point here. And the question is, if anybody's got a calculator, which one of the following values best estimates the mitral orifice area? So the number was 561 milliseconds. So does anybody with a calculator want to give me the answer? 1.4. It says, yes, that's the correct answer. And why is that? That's right, exactly. So this shows increased transvalvular velocities in a prolonged deceleration time, which I measured for you. Given the known deceleration time, the relationship between the deceleration time and the mitral pressure half time in seconds is 0.29 times the deceleration time. And you can calculate that and put it into the Hatley formula, 220 over the pressure halftime. Or, as you guys are faster and quicker than me, 759 over the deceleration time gives you the answer. So 759 divided by 561 comes out to roughly 1.4. Okay, one more case here real quick. Everybody's seen this case a million times. Okay, so a 54-year-old man comes in complaining of shortness of breath and abdominal bloating. He has distended neck veins, a soft early systolic murmur, an early diastolic rumble at the left parasternal border, and he gets an echocardiogram. Here's his apical four-chamber view.
Not the Mayo.
It's not the Mayo.
Ouch.
Just a little bit of color Doppler in one plane. Consider this representative of the other planes. And this spectral profile. Okay? This is continuous wave Doppler across the tricuspid valve. And the questions are, based on this clinical presentation and the imaging that I showed you, which of the following statements is correct? So you would expect prominent diastolic flow reversals in the hepatic vein. The pulmonary artery systolic pressure can be measured accurately in this case with the information I've given you. Mild to moderate tricuspid insufficiency is present based on the color flow Doppler. The spatial extent of the color flow disturbance will underestimate the severity of disease, or tricuspid stenosis is the predominant valvular abnormality. Do you want to go back and see the images? Okay. Apical four-chamber, color flow Doppler, and the spectral profile. Okay? Does anybody vote for A? You expect prominent diastolic. Okay, we have some voting for A. Okay. Pulmonary artery systolic pressure can be estimated accurately in this case based on the information. Nobody's voting for that. Mild to moderate tricuspid insufficiency is present based on the color flow. Nope. Spatial extent of the color flow disturbance underestimates disease severity. I see a lot of hands going up for that. And tricuspid stenosis is the predominant valvular abnormality. Okay, so the correct answer is D. The The spatial extent of the color flow disturbance underestimates the disease severity. So if you just look at the four-chamber view here without the color on, you can see that there's no coaptation of these tricuspid leaflets. This patient has essentially wide open tricuspid insufficiency and is a remodeled right heart. The RV, as Larry Rutsky shows you, is apex forming in this case, severely enlarged right atrium, and systolic bulging toward the left. And you can see that the color flow is just basically sloshing back and forth here. So the color flow, if you looks underwhelming, it's because the pressure in the right atrium is rising very rapidly. So it's equilibrating very quickly. And this is a classic spectral case of someone who has severe tricuspid insufficiency. And you see increased flow velocity across the valve because of the huge regurgitant volume. Okay? So if you see this, and the other thing that's important here is how filled in the spectral profile is. The regurgitant profile is as filled in as the antegrade profile. So this is Table 8 in the 2003 guidelines on assessing regurgitation. And you can see that this person has all of the characteristics of someone who has severe tricuspid insufficiency. So he has remodeling of the right heart with a severely dilated right ventricle and right atrium. You can see there's poor leaflet coaptation. I didn't give you the vena contracta, but if you actually measured it, it's very wide. We didn't do a Pisa radius, and he has a very dense triangular profile with early peaking, and he would have systolic reversal and not diastolic reversal expected in the hepatic veins. Thank you very much for your attention.
Thanks, everybody.